Jump in.
Yeah, it's been a while.
We do our pregame dance. So I was looking at this, right? And the first bullet point that I had on my list was, how do you pronounce it?
I read through your searches.
And you notice I didn't say what we're talking about because I don't want to give it away. I watched YouTube videos on this.
Yeah. I think I know how I would say it, but after reading through your searches, I also know that it has very varied pronunciations.
Yes. So we're talking about Guillain-Barré.
Yes.
And I've always called it Guillain-Barré. I know.
Not Guillain-Barré?
No. And apparently that is a relatively common thing. But so you saw the searches because I was like, oh, I want to know. Because I thought for a second that, it was Guillain-Barré, like people in America. I don't mean that in a rude way, but like in the American pronunciation of Guillain-Barré. And apparently that's okay. Like that's accepted. But the Guillain-Barré. I watched this YouTube video of a French guy, and it wasn't just like, because if you ever YouTube like how do you pronounce this word? They'll have very generic, things. And it was like, but this one's like an actual French guy actually talking, and he was like, "This is how you say it. If you want to say Guillain-Barré, that's okay too." Like he's going through the whole thing,
like doing an American accent when he did it too.
Yeah,
oh
yeah, it was funny. He was like, "No, that's okay." He's like, "Because I understand saying Guillain-Barré." I was he says like Guillain. Guillain. Yeah, because remember in the search when it was like, do this with a nasally tone, like something in there. I was like,
specifically,
we'll call it GBS. How about that?
Yeah, that's fine.
Yeah, so we're talking. No, let's not even call it GBS. Let's call it immune-mediated polyneuropathy.
Okay, yeah, that's a good. I mean, because we have talked about it is kind of sort of it is an umbrella term. This is not specific to one specific pathology. It's a autoimmune, it's mediated process, but that causes several different disorders.
Right. And when we get to those disorders, I'm not going to get too deep into them.
Good.
They make me want to scratch my eyes out.
The one that we will be talking about is by far and large the most common and what most everyone has learned about. And I think percentage wise about 85-90%.
I think it was 90.
About the 90% of the presentations. So by far and large the most common. Obviously, whenever you're going to be dealing with one of these patients, your neurology colleagues are going to be involved. And if it gets, further into the neurology gobbledygook, then they can address that stuff.
Right. So neurology gobbledygook.
Yep. Through the gobbledygook.
New shirt.
Yep.
What if we do gobbledygook t-shirts for each specialty?
Anything that's not critical care. Like, that's nephrology gobbledygook. That's neurology gobbledygook.
You say that in rounds, they're going to make, stop saying that. So just to be clear, right, we talked about the umbrella term, right? So the most common form of GBS that we are talking about is acute inflammatory demyelinating polyneuropathy, right? AIDP. So whenever you're looking at your neurologist's notes, like it's going to say something, like it might just say GBS, but if they've been inpatient long enough that they've figured out exactly what it is, then it's either going to say like AIDP, AMAN, AMSAN, or there's Miller-Fisher.
There's Miller-Fisher. I just remember
I feel like I'm missing one. Yeah. So, and we'll get into just a little bit the differences between those. And I'm going to be honest, they're not that big of a deal. Right. They just kind of increase in severity and become more central in their area of effect. Would you agree with that? So Guillain-Barré, this is one of those diseases that I always feel awful for someone who has it. Because it's like inevitably it's one of those things where you're like, oh, this is going to be a long road for you.
Well, and something that, as opposed to some chronic disease processes that we see that come into the ICU that are in an acute flare or have decompensated, like this isn't because of anyone's lifestyle choices. This isn't anything to do with choices that they've made. This simply is just an autoimmune process that could, truly affect anybody. So yeah, when they come in, that it's going to get worse before it's going to get better, right? And likely it's going to get worse before it gets better, depending on whenever they're presenting. But yeah, that's going to be a long road to recovery, road to recovery.
Well, and it's so fraught with potential
complications,
D-cubes, VAPs, any number of things, that can happen. Anything, because a lot of times you're going to be inpatient for a long time.
Ileus, colonic pseudo-obstruction.
A DVT, PE.
There
it is. So I figure we talk about triggers, right?
Yeah.
GBS triggers.
Yeah.
And this is also another thing that freaks me out all the time because it's just like, oh, I just had a little, like every time I get a little gastroenteritis,
Just
I'm
a
like,
little-
is this it? Is this the one that gets me?
That's my point that I'm making. It's like you could just be a normal person going out your daily life. You got some little bit of a bug.
I got a little
you feel
Campylobacter jejuni in me.
You feel a little under the weather, and then boom, acute inflammatory demyelinating polyneuropathy.
It's awful. Yeah. So as I mentioned, gastroenteritis is the primary thing. It's usually a Campylobacter jejuni.
Correct.
There's a couple others. So,
which is the test question.
Campylobacter.
Right.
Yeah.
Campylobacter.
Yeah. There's Campylobacter. There is Epstein-Barr virus, Zika virus,
CMV,
HIV, CMV, and Burgdorfy. I can never pronounce it. It's the tick thing,
bites.
isn't it? Yeah, the tick thing. So those can all cause it, but most frequently, I forget, it's some huge percentage, like the vast majority of them come from Campylobacter jejuni. And
what about when you got your COVID vaccine?
Oh, yeah, that's right. So influenza vaccine, COVID-19 vaccine, COVID-19 infection, and influenza infection as well.
Correct. Yeah.
So those are kind of viral etiologies. I feel like there's one more bacterial. Oh, yeah. Oh, man. Mycoplasma pneumonia and Haemophilus influenza. Got it.
Also, H flu and Haemophilus and mycoplasma, very common causes of community-acquired or walking pneumonia. So, these aren't super rare things to get, right? Some type of viral syndrome, some type of gastroenteritis, some type of community-acquired or walking pneumonia. These are common pathologies that could potentially result in this neuromuscular.
Well, we dealt with a case fairly recently that was kind of mysterious to us at first because we're like, that didn't seem like there was a preceding event, right? Mm-hmm. But then, sure as heck, we ended up popping positive for H flu.
Yeah.
Yeah. So, so those are the normal causative agents. Because I know you're the cell nerd, do you want to get down and how the jejuni tricks your body into attacking your myelin sheath?
Yeah. So just as in other forms of acute weakness in the ICU, and other common etiology that we see in, or pathology that we see, is myasthenia gravis. And we've talked about that a little bit. Also an autoimmune mediated, and essentially your body is creating antibodies against a specific pathogen, right? In this case of Guillain-Barré. Mm-hmm. But those Guillain-Barré. And but the antibodies that you're making cross-react with a piece of tissue in the body that carries similar characteristics. And so then
you don't want to try and say it.
I'm going to say it. I'm just trying to give it a down low on the whole thing. Yeah. And so then these antibodies, instead of attacking the pathogen or the abnormal substance that's in the body that they were formed to attack against, starts attacking the body's own tissue. And then it causes this problem. So I had to look it up because I wanted to know. I was like, why are the antibodies that are created after a Campylobacter infection specifically going to cause autoantibodies to target the myelin sheaths and cause?
You're like, what does the myelin sheath have to do with this?
Yes, exactly. Yeah. So I got my little notes up because I'm not going to be able to say otherwise. But the immune response mounted against a microbial antigen. Antigen is just any type of like badness that's not supposed to be there, right? An antigen isn't just isolated to a bacterial cause. It can be viral. It can be something else that's irritating the body. So body cross-reacts with this microbial antigen, and it can react with structurally similar epitopes. That's when I said the tissue in the body. But Campylobacter in specific expresses this lipo-oligosaccharide, right? And so you make this autoantibody against this specific lipo or oligosaccharide, which is also very characteristic of the myelin and the Schwann cells. And so that's why it cross-reacts and starts attacking your myelin sheaths, because this is a demyelinating, so attacking the myelin polyneuropathy. So that's why Campylobacter specifically results in these antibodies attacking there.
And there's some clues in the names about where this thing exerts its effect, right? So like one of the points, and this is like maybe level, like if level 1 medical terminology is just understanding like a position or a thing, like describing what something is, this would, I think, be like level 2 in the sense that, when we talk about like polyradiculopathy, radiculopathy, you hear all the time, just refers to usually the nerve root.
Right.
So I think one of the important things in this is the center of effect, because it's going to be different, like Guillain-Barré relative to myasthenia gravis, relative to multiple sclerosis. Those are all going to impact different parts. And broadly speaking, and we're not going to do like a whole neuroanatomy lesson here.
God.
Good news though, I will caveat really fast. If you go over to our YouTube page, I actually have started creating public playlists for these things. So if you're interested in good videos, which there's only one on there right now, but that's where I'll be putting them in. And Medicosis Perfectionalis does a great video on this where he talks about like the 8 cardinal rules of neurology and how let me rephrase that, what you should be able to either, contrast against or figure out if it's this or that.
Yeah. No, I love that too, that you're providing that other resource, because obviously we had to accumulate our knowledge from somewhere. And so we're obviously using lots of other resources to kind of form our own perspective on things that we present here. So we'll be able to let you guys watch some other stuff that can provide good.
Yeah. And I was thinking about it, and I won't go, this isn't like a super deep thought, but I was just like, as you listen to this, because you and I do the same thing, we'll just mainline a bunch of different like YouTube videos while we're in motion somewhere. And you will hear, like specifically like the B-cell mimicry stuff.
Yeah.
You will hear that described so many different ways. And yes, they're all technically true, but sometimes you hear it a certain way and you're like, that makes sense.
Right.
I like that. That clicks for me. You know what I mean? So, the Diet Coke has come back.
Let the dogs out.
Yeah. So we'll talk as far as, neuroanatomy is concerned. You have your central nervous system, you have your peripheral nervous system. This is a peripheral nervous system problem.
Nailed it. I love that.
Done. Cast over. Cast is over.
Mic drop.
Yeah. But so the point is that your central nervous system is going to be your brain, your spinal cord, and your optic nerve. That's about it. Your peripheral nervous system is essentially everything else, like everything that feeds off. And then a lot of people will often mistakenly categorize cranial nerves as central nervous system, but they're actually not. They're centrally located,
right,
but they fall under the guise of the peripheral nervous system. And, like when you look, and there's a lot of really cool facts about the optic nerve. One day I'm going to do a whole video about the optic nerve, but the optic nerve.
Can't wait.
The optic nerve is its own self-contained unit, essentially has its own covering and everything. And it's the only external expression of the central nervous system that you can look at.
All right. So, very interesting.
But there's a lot of, at some point, and I'll have to make like a list of, certain things that have ocular manifestations, which then you can differentiate as being a CNS, affecting thing.
Right.
So anyway, this primarily affects the peripheral nerves. Like you said, it's going to demyelinate. It's going to make them not be able to, conduct signals. I think that plays into its presentation.
Yeah.
And again, I tried hard in this episode to not make this a Guillain-Barré and myasthenia gravis or and something else, because you could spend hours contrasting those things.
Right.
So because, let's take myasthenia and Guillain-Barré, because those are two very common ICU entities. They're almost opposite. Yeah, kind of in the way that they present, but similar. So it gets confusing in the sense that one's ascending, one's descending, right? So Guillain-Barré is ascending, right? So our weakness is going to start in our legs and our hands. Symmetrical, not unilateral. Right. Unilateral weakness is a red flag sign.
Unilateral weakness with any other signs of, neurologic dysfunction should. You need to be trying to localize a lesion, scanning ahead, doing all that stuff, which I'm not saying you're not going to do in this case, but this is symmetrical, starting periphery, like you said. Mm-hmm. Traditionally they'll say, start in the legs, but that's not to be confused with it starts peripherally, it works centrally. So hands, feet, going to work its way to the midline. Mm-hmm.
And that's actually a really good point, right? Because some people may be more sensitive to weakness in certain areas than others. Yeah. So like a lot of people may notice it in their hands first, right? But there are, I'm trying to remember, there's 2 scales, right? There's your Brighton, There's your Brighton scale. So before I jump down this, let me make this one statement. Guillain-Barré is primarily a clinical diagnosis, right? Like it's not like you're going to snap an MRI and go, got it.
Yeah.
There, we got him, folks.
There's no characteristic, radiographic findings that you're going to be able to see. You can send for special autoantibody panels and stuff like that I don't know that your neurologist will send.
Do they ever?
No. And this is going to be, it's going to be a send out. It's not going to come back in time. So this is like a lot of things in critical care medicine. It's like if you meet a constellation of symptoms and it fits the picture and you've got your neurology on, colleagues on board, and this is the most likely etiology, you start treatment regardless of having, confirmatory testing.
Right. And that is, I think, a great point. Early treatment is crucial.
Right.
So when these patients present and you have any suspicion, you need to try and figure it out pretty fast. Not always. Sometimes it can help. Outcomes as far as this goes, I think we're talking 80% full recovery, if I remember correctly. And then from there's gradations. There's usually some degree of people who have some form of neurologic disability afterwards. So, we see this when we see these patients, we often will think like, okay, yeah, it's a long ride, but we'll get there as long as we do everything right. And it's like, it still might not be a positive outcome. We had mentioned, I think, as far as presenting symptoms go, obviously we have ascending weakness. The textbook answer will tell you like it starts in the feet and then will go to the hands and then comes in peripherally. Sometimes, like we said, that's not always the case. And I think we always try to make the point in the podcast to say like, we like to cover what the textbook says. We like to cover what the literature indicates. Right. We also like to indicate what you might see,
right,
which was going to deviate from that.
In that, just like you said, we're not going to cover myasthenia, but it is helpful, I think, to contrast the two. Because whenever I learned about these, an easy mnemonic or, kind of thing that I used was like myasthenia, MG, so mind to ground. Like myasthenia is normally going to start at the top. You're going to have, ocular weakness, bulbar symptoms, ptosis, and then myasthenia is fatigable, right? Those are like, just big hitters. We're not going to cover the whole thing. But then when I did Guillain-Barré, I said ground to brain. So it starts peripherally, but just not to be confused. I want to say that because when I was like, ground to brain, like Scott's starting your feet. No, that's not the case. It's starting periphery, ground to brain. But one thing to contrast between the two here, and this makes sense when you look at the underlying physiology of the two. Myasthenia is autoantibodies against the postsynaptic acetylcholine receptor, but in Guillain-Barré, it's this demyelinating disorder. So you're not only having problems sending efferent messages, but also receiving afferent messages.
So it's sensory
data. It's sensory as well. So in that, your reflex arc is going to be impaired. So in Guillain-Barré, you're also going to be either hypo or should be areflexic.
Right. Yeah. So, and, to your point, right, about the whole, your bulbar weakness, right, that can be present in Guillain-Barré, but the rest of the clinical constellation is going to look different.
Correct.
And by the way, if it makes it up to your eyes, you're in trouble. I'm just going to say that you're on the opposite end of the spectrum and things aren't looking good for you.
Yeah.
But there's let me run down the list real quick, right? So symmetric peripheral ascending weakness, reduced or absent deep tendon reflexes. You can have paresthesias, tingling, numbness. Obviously, you can have diaphragmatic weakness. And again, when you're in your mind's eye, when you're like, well, how does it hit all the things? They're all governed by the peripheral nervous system.
Right.
So they're just making their way downtown.
Start singing that. If we would have done it at the same time,
that would have been good.
Oh, should I not?
Yeah, that would have been good. So, and as obviously once it crosses the level of the diaphragm, you're in trouble.
Yeah.
As we said, you can have that bulbar weakness. You can have, a weakness of the eyes, mouth, dysphagia, aspiration risk, all this stuff. It's rough. And there is, it's the Brighton criteria. I am going to look it up because I don't have it memorized at all. But this is so it's like a 1 to 4 scale, and it's essentially the likelihood that you have Guillain-Barré syndrome.
Okay.
And the categories are bilateral and flaccid weakness of limbs, decreased or absent deep tendon reflexes in weak limbs, specifically weak limbs. You have a monophasic course, meaning that that something happened before this. and the time between onset and nadir is 12 hours to 28 days. That's the other thing I wanted to mention about this.
Yes.
Is it happens like 4 to 6 weeks after the precipitating event or the monophasic course, if you want to be.
After, and just to make sure
I
we
like when
understand.
you put your hand out and you're like,
I don't know if they can't even see it,
hold
so
yourself.
it doesn't matter.
Hold yourself back, folks. I'm about to hit you with knowledge.
It's, after the preceding illness, so whether that was the gastroenteritis, the viral prodrome, whatever.
Yeah.
But this also separates things from other forms of polyneuropathy, right? Because as we say, AIDP, as this is Guillain-Barré, it is important to acknowledge that this is acute, right? So if these symptoms develop over the course of 2 to 3 months, then it's sure as heck, I mean, I can't say with 100% certainty, right? But it's probably not Guillain-Barré. This should be an acute onset after the preceding, what do you call it?
The monophasic course.
The monophasic course.
Yeah.
So there is a form of chronic inflammatory demyelinating polyneuropathy that is also in the neuro bag of
which we are
neuromuscular,
not talking about.
Which we are not talking about. But just to illustrate time of onset.
There you go.
Okay, nailed it.
Yeah.
Better.
Yeah, get on it. Soften the lips.
I feel like I'm spitting on it, it's like a little too close. So just to illustrate the difference in onset of symptoms can help you differentiate this from potentially something else or rule it out as well.
Yeah. What's the other criteria? Absence of alternative diagnosis for weakness. And then there's some other things in there that we'll talk about later as far as the albuminocytologic dissociation.
Dude, that's a grab bag to say that you have to exclude
I know.
I mean, the differential for this, should we just mention, is extremely broad.
Yeah, they put that in there so that you make sure that you're going to meet your out of pocket before this is over.
I mean, right. I mean, I can't even list them all off. I'm not all in the neuro, but I mean, this could be, again, you would say it would be more unilateral, but this could be a focal lesion. This could be a CIDP. This could be any type of myositis. This could be tick-borne.
So I think you can get to the right, what's the saying? You can get to the right church, but it's going to take a minute to find the pew, right? You can get there pretty fast. So like we said, there's no magic bullet. You can't MRI this and go, oh, nailed it. You can do CSF studies. And as we mentioned, you'll see
Now you did it to me.
Albuminocytologic dissociation. So it's
and it's just it means that you just have an elevated CSF protein, but without a cell count or all these other things that would clue you into thinking that this is some type of acute inflammatory or bacterial viral etiology.
Yeah. The other thing is EMGs. So
yeah, I think neurology will order those. It's a nerve conduction study is what he's talking about. And so they're essentially going to provide a stimulus and see the rate at which that stimulus travels through the nervous system. I don't know how to read those. I don't know what it means. I'm guessing it's going to say it's slow and impaired.
Yeah, when I used to do like neurosurgery and stuff, I would look at, because every spinal case is getting EMGs, and I'd try, because it's like I like looking at EEGs, right? I can usually tell when something's bad on there. I'm not an epileptologist by any means. I can just go, oh, you're really asleep, or oh, you're having seizures right now, which is basically all you need to know when you're in critical care. But when I look at the like EMGs and stuff, I'm like, that's gobbledygook.
That's gobbledygook.
That's a lot of gobbledygook, folks. Yeah, that's what I get for drinking Diet Coke while I'm doing this.
Yep.
So, what did we do? We did presenting symptoms, your essential inclusion criteria, some diagnostics that you can perform. Just for the sake of being thorough, I'll explicitly list the types. So your primary, as we mentioned, is your acute inflammatory demyelinating polyneuropathy, AIDP. So when you see that, that's going to be your most common one. Now, there are other ones. So you have acute motor axonal neuropathy, that's AMAN. And then you have acute motor and sensory axonal neuropathy, that's AMSAN. And then you have Miller-Fisher. And essentially, I'm going to broad brush this whole thing, right? As you go down that list, the severity gets worse, and your probability of good functional outcome becomes lower. I'll just leave it at that.
The worse the name gets,
The longer, the harder it is to say or remember, the worse it is.
Yeah.
And then from that, there's other variants. There's pharyngeocervical brachial, and then what?
Okay,
hold on.
well,
Bickerstaff brainstem encephalitis.
Yep, that was definitely the next thing I thought we should cover.
And paraparetic variants.
Yep.
Bunch of blah, 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 blah. So treatment.
Yeah.
You want to go over treatment?
2 different flavors here. I should probably know before I say this on the podcast. Don't know that there's necessarily any benefit to one or the other, but I think the most common is going to be IVIG, right? That you're going to do first.
Okay. I didn't know where you were going with that for a second.
Because another option is plasmapheresis, but I think by far and large, most people are going to start with IVIG on this, right? So it makes sense intuitively if you're thinking about the underlying pathophysiology. You have these autoantibodies attacking your own tissue, these myelin sheaths. We're going to provide the body with additional antibodies, one, to compete at that antibody binding site, 2, to kind of wash out the bad antibodies, if you will.
The IVIG is like throwing a dog a bone.
Yeah.
It's like, go get it. And then you throw it out there and then hope it stops attacking you for a second and goes after the bone.
You're a good boy.
And then while part of them's gone, you're like, let's clean the blood.
Yeah.
And then they come back and it's all, gone.
So alternatively to that, another option for treatment is plasmapheresis. And essentially you're going to hook these patients up to a pseudo HD setup, right?
Yeah.
And you're going to pull off the bad antibodies.
Do you want to explain what a pheresis is?
I do not. Do you?
It involves electricity.
Okay.
It's like, do you remember, I don't remember if it ever made it on the cast, but we were talking about the mechanism by which hepatotoxicity occurs in acetaminophen overdose. And it has to do with like that pheresing, stripping electrons out and like destabilizing stuff.
No, but I mean, pretty much everything carries some type of an electrical charge, right?
Well, no.
Okay. You get what I'm saying.
I almost said a swear for the first time on this show.
So what? You're just applying some electricity and magnetizing that stuff.
I don't want to talk to you anymore.
I don't know what you're talking about.
No, you're gonna sit there and poo-poo me, Mister. Oh, the antigen presenting cells.
I don't know anything about plasmapheresis.
I'm gonna make you the next limited release T-shirt's gonna be for you. It's gonna be cellular biology gobbledygook. The back of it's just gonna say antigen presenting cells.
You can't give it that tone and connotation. That's the only bad thing.
So you really don't. Your treatment options are few. The efficacy of which is you're hopeful, right?
Yeah.
That's going to work. And then the rest of it's time. Did you want to add something?
I was going to say with time is obviously an asset. So part of the problem is like if you give IVIG, right, and you don't think that it's working, and then you do plasmapheresis, well, you're going to try and get rid of their bad autoantibodies, but you're also going to plasmapherese, you're going to pherese, the thing that I don't know how it works, off the good antibodies that you just gave them as well, right? So you need to have a certain amount of time that once you start IVIG, right, you need to wait a certain period of time to see if they have improvement. I think that this can happen more precipitously, but it can take up to, 2 weeks for you to have clinical
Well, there's
improvement.
like, for people who do, oh geez.
Oh boy, bud.
Oh, bud. Myasthenia.
Is that their bulbar symptoms?
A lot of times when you hit them with IVIG, they tend to pop back.
Right.
Tend to. Not always, but those are ones you'll see. These patients, they're not going to be like, my toes are moving. That's not going to happen.
I think a good point too to include here is like once you have GB, it's not like this stays with you the rest of your life, right? If you receive treatment and you improve clinically, like people who get MG, myasthenia, you treat them for their acute flare, but then they still have MG, right? Yeah. So that's another important part of the fact
that still exists
to paint. Like you will still need to be likely on outpatient acetylcholinesterase inhibitor or something like that for your MG, and pending appropriate circumstances beforehand, you have a critical illness, your immune system is knocked down, something like that, you have an MG flare. Like you don't get rid of MG. The point of treatment in GB is to get rid of, like it's an acute onset, and we are treating you with the hope of eradication. Like you will no longer have GB.
I had an individual once who treated their myasthenia with kale shakes.
Like the plant? Kale?
Yeah. And like super high dose D3. This is not medical advice, by the way.
How did that work out?
Not good. Not
They
good.
gave themselves gastroenteritis.
It was, well, this individual ended up spending a fair amount of time in the hospital.
Yeah.
And this was actually a person I felt really
They were
bad for
pooping their
because they got
pants.
kind of stuck in this like stasis realm where like they just couldn't get off the ventilator. And I forget, so when we got that person off the ventilator, they were on BiPAP a lot. And this was a long time ago when I worked nights somewhere else, not here. And I was like, it was like 5 a.m. He's like, I just want to go outside and see the sunrise. I'm like, all right.
Walk out there.
Well, if you could make it. No, I was like, all right. So I threw him into a wheelchair and I took him outside.
Hey, that was a good thing for you to do.
We made it to the door and we got to watch the sun for about 2 minutes. And I was like, we got to go.
Yeah.
We got to go. We got to go back inside.
Should we use that to segue into
The
some things
NIF.
that we actually care about in the ICU?
The lungs.
Management of this is, when is this going to potentially result in respiratory failure, and when do we intervene on such?
Right. Well, as the resident respiratory therapist, would you like to go over the negative inspiratory force measurements?
Yeah, and the FEC.
And I want you to beat down why this is so important, because the amount of times that I'm like, I don't see a NIF in the chart.
Yes. I think it, to your point, is important for the clinician who's caring for them and for the other staff and the other consultants that are following along. However, I do think that from a respiratory standpoint, and now as a critical care provider, I don't think that anything trumps your clinical gestalt.
Gestalt. We'd be goosing it. That's the next t-shirt. It's going to be a goose that says your clinical gestalt.
Your clinical impression of the patient and how they look from the door, how they look on exam. Do they have accessory muscle use? Are they tachypnic? Are they hypopnic? Are they just like, hypoventilating like crazy? Everything that we do on a regular daily basis to assess someone's need for intubation, mechanical ventilation. Are they having bulbar symptoms? Are they able to phonate? What's their swallow look like? Can they cough? Can they clear secretions? Can they lift their head off the pillow? Like all the stuff we do on a daily basis. So, because I know that you have also seen it as well. Now, admittedly, I can't remember if this was an MG or a GB patient that I had, but, throughout the course of their maneuvers that we were doing them to assess respiratory strength and function, those looked like absolute garbage, but the patient continued to look fairly clinically stable. And we did not proceed to intubation and mechanical ventilation purely based off of those values.
Yeah.
So I'm not saying that they're not important, but I also don't want it to come in to play that we say, oh, their NIF was negative 15, like, get the intubation box ready and we're intubating this patient now.
Yeah,
right?
No, that's actually a really good point. I'm going to move this for a second because I'm going to get intimate for a second. Listen to me. We've said this before. We don't make decisions on single data points, and definitely not just numbers. You hear me?
As a father, I just,
and we're back.
I feel like a little bit of guilt, and I shouldn't even anything. It's like, I'm sorry.
Hold on, one more point.
Yeah.
Listen to me. If you have a patient that's got Guillain-Barré syndrome, you better know what the NIF is.
Okay, so NIF stands for negative inspiratory force. And the best way that you can think about this, if you have never performed one or seen one done, is my kids like to get Brahms after church on Sundays, right? And you
Let's go, Dad of the Year. Let's go.
Killing it.
Well, I want Brahms now.
I also don't want to go home and make lunch after we've been at church. We get there early and like, okay, let's just get you some lunch.
Dude, if you go to church, you have to go out afterwards.
It's obligatory.
That's it. That's what you do.
Yeah. So they'll get a kid's meal and it comes with a shake, right? Man, they be making them shakes thick. Okay, I'm talking. So I have to ask them to make the shakes kind of thin for the kids. But if you've ever gotten a thick milkshake and you've tried to suck up some of that milkshake and you are just giving it all you got and it's not coming up the straw, that's what it's like to do a NIF. So we are assessing your negative inspiratory force.
Negative.
So they will give you a mouthpiece. There is some type of a manometer with an occlusion device. They'll tell you to suck in as hard as you can. Mm-hmm. They will occlude it. That occludes, the inlet for the air to flow. And they're going to measure on a scale of, is it millimeters of mercury? I would presume
You're a respiratory therapist. Why are you asking me?
A numeric number, essentially.
The machine looks like a Game Boy.
No, that's for the FVC.
Oh, yeah, that thing. Never mind.
This is just a little like manometer type deal, and they'll measure it. It will give you a number. So normally, I mean, me and you sitting here, we should be able to pull a NIF of like negative 60, probably, you know, depending on how hard you go.
I could do 65, probably.
I could probably do 67.
100.
Oh. So anyways, the point being that once that NIF falls below negative 30, then we're getting worried about respiratory muscle involvement, diaphragmatic function, that type of thing. So anything below 30 on that point, you're starting to become concerned.
Your TBH score goes up a little bit.
Yes, it does. Little clinch.
Yeah, maybe like 2 points, right?
Yeah.
Not super bad.
Nothing bad.
I'd said, someone commented on a TikTok, Luke, and he said something about, I don't remember what his exact comment was, and I was like, TBH score greater than 10 equals Jesus take the wheel.
Oh, yeah. So in conjunction with the NIF, we're often going to perform or an FVC as well. I don't really see a utility in having both values. I would just pick one or the other. Truthfully, when we're talking about this as a former RT, I kind of prefer the FVC because the NIF can be both patient dependent and provider dependent, or whoever is administering the test.
I was going to bring that up.
Well, too late. I'm bringing it up now.
Well, I do remember that case we had. This had to be a year ago at this point.
Were you just getting very discordant numbers?
Where they were like, this patient looked clinically terrible, and they're like, their NIF's like 45.
And you're like, no.
I'm like, that can't be.
That's why we look at the patient.
Yeah.
Right. But the NIF can just vary widely based off of who's administering the test and who's performing. I mean, if you wake somebody up in the middle of the night to do a NIF,
right?
2 a.m.
You got to have good patient.
They may
effort.
not perform that test very well, and then it looks like you got in, and we shouldn't be running it in there with the intubation box.
Right.
So an FVC is you're taking a normal tidal breath and you're blasting it out as hard as you can. You can get an FEV1 from that, but then also your forced vital capacity, almost kind of like a sigh breath. I think that this is a little bit more standardized as far as the administration technique, and it does require obviously patient effort, but it's not as patient effort dependent as a NIF.
Right.
So, exhalation in the respiratory cycle should normally be a passive process. We're not engaging any muscles to do so. But if you're going to exhale forcefully, you do have to engage your respiratory muscles. Yeah. And so by checking that, so a normal FVC, we should have like 60 mLs per kg, something like that. So anytime the the FVC falls below, again, that 30. So it's nice because you can think 30 on both sides. A NIF less than negative 30, or an FVC less than 30 mLs per kg, then we're getting concerned about respiratory function.
Yeah. And like you said, this is a data point, like anything. And this is why it's important to know them. And when I say that, don't just know the one that was done this morning. I want you to know what yesterday's was and what the trend is.
I put my hand up so they could see that. That is the most important part. That's why we're tracking these numbers, is not because we're going to make a decision based off of a singular value, but that we have data points to trend. And then you can see, okay, they look okay now, but the NIF has gone down 15 points over the last 24 hours. Mm-hmm. Should we consider supporting with non-invasive now, or should we just be on lookout that, in the preceding 12 to 24 hours that this may progress further and we need to be ready for intubation? It also gives you that opportunity to be more prepared for this, right? So that it's not your classic ICU situation where someone's, they're crashing, they're not protecting their airway, and it's a RSI situation.
Yeah. And, kind of like we said before, we've said this probably ad nauseum at this point, right? Like, obviously, too much data can be a bad thing. But as you're going through, he's like, no, give me all the data. But as you're going through this, like with any clinical scenario, you're going to have, things that you're going to have a tally going in your head of how, concerned you need to be, what boxes you're checking along the way. So when you have like a patient and you're hearing about them and they're like, oh, they're a little bit hypotensive. Oh, their SADs are kind of low. Okay. Well, and their NIF is -14. Okay. And then you go in there and then they,
and if you're, for me personally, I don't know about you, but if they're borderline, this is somebody I'm totally fine with supporting with non-invasive.
Yes.
Right.
Yes.
So this is not in lieu of them having any bulbar involvement and aspiration risk concerns, but this is not an underlying physiology that you're concerned about, not putting them on a BiPAP because they have a pneumonia or these other things that are potentially, relative contraindications to BiPAP therapy. The only caveat I would say to that is, as we alluded to, like this is going to get worse before it gets better. Yeah. So unless you think that they're going to be on the upswing in the very near future, if you're putting them on non-invasive and they're becoming essentially BiPAP dependent, like you might as well just intubate and sedate this patient, because this is not going to get better in 12 hours. This is going to be something that's going to improve over time. So,
and on top,
could be putting them at a detriment.
I'd say early trach discussions, like especially if you don't think this is going to go well.
Right.
Let's go ahead and get that out of the way.
Right.
Just because you don't want them to sit there on that vent for 14 days.
Less risk of ICU delirium. Yeah. Less risk of ventilator-associated pneumonias. All the things that come with that, potentially CODIs, like all these other potential things that the patient could be at risk at just because of that prolonged mechanical ventilation course.
Yeah. I was going to say, I don't want to get all up in the camera's face again, but I was just going to say very nicely this time. Remember, folks,
buttery tones.
Intubation is not always the answer.
Usually. No, I'm just kidding. But
often, but not always.
But not always. No, I'm just kidding. He's 100%. I mean, I think we could all do a better job, myself included, of a little more Zen-intensivism to steal that from the IBCC. Maybe just put them on non-invasive and sit back and chill for a little bit, or
dude.
Or maybe we can aggressively diurese them and support them for 3 hours and reassess instead of just rushing to, oh my gosh, I need it.
Right. Yeah. Because how often do things get like, there's not just the risk of the intubation itself. There's peri-intubation hypotension, shock, risk for cardiac arrest. Like none of that stuff is benign.
No.
Vocal cord damage during intubation, like there's some, and obviously if you're going to go to the mechanical ventilator conference this year, we'll cover all these things in depth.
And that's a very good point, because I did want to outline, we kind of mentioned it a little bit earlier, but because of the form of neuronal injury that occurs in GB, this isn't just, like we said, like a musculoskeletal deal. This isn't just the weakness. There are other manifestations of this. And so one of those, again, I talked about how afferent, efferent are both going to be messed up, like with reflexes and stuff. So this is going to be musculoskeletal. This is going to be sensory, but this is also going to be autonomic dysfunction as well.
Yeah.
So in the peri-intubation period, right, like intubation is going to cause a vagal stimulation.
Right.
And then if they have dysautonomia or impaired ability to upregulate their sympathetic tone, they may be pumping it out, but if you can't send it peripherally to the central or the peripheral nervous system to ramp up your heart rate, to increase your stroke volume, all that kind of stuff, these patients could be at risk for the peri-intubation hypotension, bradycardia, blocks, even asystole. So just as with any other intubation, we need to make sure that they're well resuscitated first. Are they any signs of hypovolemia? Do they need a fluid bolus? We should have some push dose pressors, phenylephrine, epinephrine, whatever the case may be, ready to go, because these patients, because of the damage that's occurring and how it affects the nervous system, could cause this to kind of drop precipitously.
Yeah, and I should have got that out before I even started. I wanted to emphasize, because I know we had mentioned it briefly in the beginning, there can be sensory manifestations of Guillain-Barré. The primary issue is often not with the sensory issues. I'm going to say this in the simplest way possible, because I know everybody, when they see that cross section of the spinal cord, like,
Are you talking like upper motor neuron, lower motor neuron?
yeah, upper motor, lower motor, you're having your, your anterior and your posterior, which is essentially the difference. You have an arbitrary line in your mind, but that's essentially the difference between your afferent and your efferent pathways. Your GBS is going to affect one side of that more than the other. However, when those pathways go downstream, they will sometimes meet.
Right.
They do meet, and then that can cause issues there. But that's all I'm going to say. If you want to reference that more again, shout out to Medicosis Perfectionalis. Great video.
I'm going to go watch it, because I'm
going to watch it right
that.
now.
Yeah.
Just gets up and walks out of the room. So, and I'll say, just to clarify, your IVIG treatments are like 0.4 per kg for something. 5 doses. 5 doses. Plasmapheresis is usually 6 treatments of plasmapheresis.
Should we mention, I think that this was, did you put out the bloopers of you guys taking those questions?
Not yet.
Okay. Well,
I need a place to put them.
It was one of those, and it's a question that me and you have both gotten on taking practice questions for critical care and stuff like that. Mm-hmm. So if you were to intubate this patient and you were to use an RSI type of setup, which paralytic would be contraindicated in this case?
Oh, it's in the video.
In the Medicosis Perfectionalis?
Wait, you haven't seen the spicy video though, have you?
Well, that's what I meant. Okay, maybe that wasn't. That's what I thought it was in the spicy video, because that was a question that
you're talking about the succinylcholine question.
Yes.
Yeah.
Okay, so you would want to avoid sucks in this situation, right? With these neurologic and neuromuscular pathologies, it's not just because this is affecting.
Didn't we bring that up recently?
We've talked about. I just can't remember on the cast. Your body will upregulate the acetylcholine receptors and that type of stuff to try and make up for the weakness. This can be seen in someone who's been down for a long period of time. Oh, that's right,
because it also predisposes you to kidney. It was the kidney stuff we were talking
about.
Right.
If they're paraplegic, those types of things. So you would not want to give them succinylcholine. You would want to use a non-depolarizing neuromuscular agent. So
thanks, brother. Anything else you want to add? Because I think the rest of it is just like, make sure that you're turning them appropriately.
Hoopla.
DQ prevention, VAP prevention. If they have a trach, good trach care. Early PT mobility is tolerated.
Yeah. I think we talked about causes. We talked about presentation. We talked about treatment. We talked about tracking clinical signs, symptoms, as well as other data points that can point us into, are they progressing to respiratory failure, which is something that we're worried about. We talked about how we can approach the respiratory failure, how you would prepare best to intubate this patient, potential complications in the peri-intubation period, and then, just good critical care after that.
Well, and we'll just scoot over to housekeeping stuff, right? Obviously, if you've been following, we have a YouTube channel that we are actively working on. Stuff like this. So if in your mind you're thinking, I want to know more about AMSAM, or I want to know what Miller-Fisher syndrome is, those videos will be coming. Those are going to be separate things that we'll do kind of in a more outlined way, so that people can, because I think sometimes, like, I know that, obviously there's a lot of yield here, but some people don't want to sit through an hour and a half.
Yeah, this is what people tend to like, and how we like to do this is more of just a conversation between the two of us, obviously hitting, pertinent clinical and educational points. But if you have specific questions, like Ron is alluding to, we'll release other videos that are strictly more educational, quick and dirty, straight to the point. This is what you asked. This is what you need to know. And not all of our other banter, although.
But you're going to miss it.
Yeah, you're going to miss it.
You're going to miss it. All right. Do you want to walk us out of here?
That has been episode
27.
Oh man, yeah, 27. I think. Episode 27 of the Volco podcast. We appreciate you guys listening. Obviously, if you followed us from the very get-go, things have progressed significantly since then. That's kudos to our man Ron over there. But obviously, continuing to always work to improve here. We appreciate everyone who's listening. We're trying to get more followers and listeners outside of our regional area. We're out on TikTok and Instagram now. We have the YouTube channel. So if you guys do enjoy this, share this with your friends. We're trying to make this for everyone. So this is for nurses, respiratory therapists, people who are in school, PAs, NPs, physicians. So share it with your other medical colleagues if you think that they would benefit from it as well and enjoy it. Send us any emails if you want to at thefullcodepodcast@gmail.com. And I think that wraps it up, doesn't it?
That is it.
All right. Appreciate you guys.
Bye-bye.